Hi everyone, thank you for joining today's webinar. The NGO whose story we are going to cover in this webinar, whose story we're going to learn and listen to, is of MLD Trust. Will experience their journey of going digital for the MCH program with Avni. We have been joined by Dr. Sujata Gode along with Dr. Chandrasekhar and the MLD team. Before we start, a quick introduction about Avni for those who have joined us for the first time and those who are new to uh, Avni. I will be sharing my screen. Avni is a product that has been built and developed by Samanvay Foundation. Samanvay Foundation, as an organization, we are digitally transforming social impact programs to amplify their impact on the field. The vision of the company is making technology affordable, accessible, and impactful for the last mile of service delivery. Our mission is to build a sustainable, open source, digitally public good that empowers NGO and government to serve the community better. As I mentioned, Avni is a product that has been built and developed by the team of Samanvay Foundation. Avni helps in data collection and visualization. It works as a platform for nonprofit organization, uh, built in collaboration with the field NGO. It helps in your longitudinal data tracking, having the offline capability, and also the application can be used in a multilingual language. Avni is an open source platform which is AI powered, very easy to use, currently been used across 60 plus projects pan India. I think without further delay, I would like to introduce Dr. Sujata and hand over the session to her so that she can share their experience. A quick introduction about Dr. Sujata. Dr. Sujata is working as the Chief Project Manager. She has been associated with MLD Trust since 1986 and has played a key role in the rural health since 2008. She has helped design the homeopathic community health worker curriculum. She has led maternal and child health program addressing anemia, malnutrition, and preventive care through the homeopathy. She has been very actively involved and spearheaded the digitalization of their field data using Avni to improve the accuracy, analysis, and the decision making of the team. Handing it over to Dr. Sujata so that she can introduce the other team members and take this session forward. Over to you, Dr. Sujata. Yes.
Yes, so thank you, Anjali ji. We have been working in close contact with Avni, whole team, and I'm very happy to share our experience of how we went from the paper to the system digitalization. Initially, I would share my screen. Just give me a minute. Yeah, my screen is visible, right?
Yes, to me.
Yes.
Yeah. Thank you. So yeah, as I said, I will be presenting the our journey. So I will be largely covering the following parts in my presentation today. We will talk about our organization. Dr. Chandrasekhar Goda, who is the director of our center, is here, and he will give us a brief about our organization. Then we will talk about our work on the mother and child health initiatives in the Vikramgarh block of Palghar district, and why we felt the need to digitalize. So the remaining portions will be covered intermittently by me and my team who is working on the field. So there are multi-purpose workers, there are community health workers, and there is a center manager, there are supervisors. So they have been working on field and they have gotten experience directly of how they were working earlier and now. So that will be covered by them. And also I'll briefly talk about the future plans, what we can do with this sort of a setup and background. So now I will hand over the presentation to Dr. Chandrasekhar Goda, who is an MD in homeopathy, and he is the Director of Clinical Growth and Development, Tribal Health Center, Mopoli. He has also incidentally done a PG certificate course in public health management. He is the HOD of pediatrics at our institute's college, which is called as MLD MHI. and he has been actually there since beginning, establishing the mobile rural health services. And yes, that's why I contributed to the community health center and the Janki Bachu Dubey Homeopathic Hospital, which is at Bhopoli, and he leads tribal community health and development initiatives. So I will now request Dr. Chandrasekhar to take over and explain what is our organization and its mission, goals, etc.
Yeah, are you able to see me? Yeah. Thank you, Dr. Sujata. Namaste and good afternoon to everyone. This is Dr. Mitra Chandra Dhawale, our teacher and guru, with whom I spent about a year in 1986, who lived on three principles. One is that any patient who would call on him would not go back without medicine, irrespective of his capacity to pay. The second principle was any student who would approach him for knowledge always received knowledge. He used to believe that knowledge should be shared and not sold. So even today in our organization, we see to it that the poorest of students, if he has got merit, gets admission in our colleges. The third principle is that he said that we have all become doctors by learning on community, especially in teaching colleges where free patients used to come. So he said that we have to spend some time in serving the community. So these three principles he lived, and we watched him closely, and now we are following his path. He also has told that we have to reach no one where no one reaches. So his concept of care related to patient was that we have to care a patient through a seva bhav or service. As far as the learner is concerned, we have to do it through sadbhavna or goodwill. As far as the knowledge is concerned, through sadvichar or good thought, knowledge should be shared. And as far as the community is concerned, he said that we always have to see that the community participates in whatever services we offer. And this is the philosophy of our organization. So in his name, we have made the trust, Dr. MLD Trust, which has its mission as excellence in integrated homeopathic medical care, education, and research in order to promote positive health in a cost-effective manner. So now, how have we been able to do all this? In the last 50 years, we have been able to provide integrated patient care, education, and research. We have seen over 30 lakh patients served mainly through charitable centers and at charitable rates. These are apart from the patients whom we see in our private clinics as well. And all this was possible because we are running 3 hospitals, 12 clinics, and 2 mobile clinics. We have a 100-bedded multi-special hospital at Palghar, which actually is our referral center where most of the poor patients get the best care in the most economic charges. And then we have the community health center developed at Bhopoli, about which the Avni center, Avni app we have applied there. We are a teaching institute. We have a postgraduate teaching college at Palghar, through which we have been teaching students. About 1,000 students have passed through our colleges and are doctors all over the country. And our institute, which Dr. ML Devle started, is going to celebrate its 50 years golden jubilee this year. And then government has recognized us as center of excellence because we used to stress on excellence. So 3 centers of excellence operate in our institute. We have about 17 internationally recognized books which we have published. We have JISH, a journal which is a well-reputed worldwide journal. Apart from that, the Ayush Ministry has asked us to work on 5 extramural projects. These extramural projects help us to do research in homeopathy so that we are able to advance the healthcare through homeopathy. Our recent milestones at Malad, we have a hospital where a state-of-art operation theatre is there, where recently about more than 250 surgeries have been offered at a very cost-effective rate. Many surgeries where patients cannot afford come to Malad so that they are able to get operated at a very cost-effective rate. Digital app Avni, which is such a wonderful thing which has happened to Bhopoli, will be shared by Dr. Sujata. 1,500 free cataract surgeries via Mahadrishti project. We are an NABH accredited organization where our recently the surveillance audit also we have cleared. Another very interesting experience we have at Bhopoli is about 600 self-help group women have actually, the figure here is 79 lakh, but they have taken over 1 crore of loan. And the best thing is that they have returned it over a period of time from the banks. What is significant is these are very poor people, but they take loan, but they return it. That's a very interesting thing which we experienced. About reaching the unreached, we began our journey in Palghar in 1989 with a OPD, and we used to travel from Bombay once a week, and we used to attend to the dispensaries there. So people from the nearby areas and villages used to come to Palghar. Over a period of time, they found that about 50 families were traveling from nearby areas. So they requested that we begin a dispensary 20 kilometers away from Palghar towards the highway. So that is in Manor. And from Manor, tribals of the nearby villages used to attend our dispensaries. And during monsoon, these tribals would not be able to reach us because during monsoon they work in their fields. And so they didn't have any access to medical care. So they requested us whether we can reach their villages. That is when our mobile dispensary started. And as we spread out to various villages, the need for the Bhopoli hospital came up, and that's how the Bhopoli hospital and the mother and child sector came. Now I will hand over this to Dr. Sujata so that she can explain to you about it. Thank you.
Yeah, thank you, Dr. Chandrasekhar. So I am working at Bhopoli now since since 2008. We cater to around 26 villages and 150 hamlets, which are actually in a radius of 20 kilometers. And mind you, 20 kilometers is not just a terrain which is a smooth terrain; it is all a hilly area, and access roads are also very winding and difficult at times. They are not there. So we are serving this type of a population where we cover 41,000 people. This is when actually, because of the terrain problems and the medical manpower problem, we realized that we need to train local people who can then take care of the health needs, and they need to be having a homeopathic orientation, because otherwise there are ASHA workers and there are other workers but who are not trained homeopathically. And for us to sustain the program, we needed people who can understand what are the homeopathic principles. So we had to design the syllabus curriculum, and we also had to create the resource books for the training program. And I'm happy to say that we could train 100 such workers who are basically women, married preferably, so that they don't go out of the hamlets, and they are at least say 7th standard pass, so that they are able to read and write and understand the instructions. So currently we have around 48 health workers who are in force and who are very closely monitoring the mother and child health program. So they are able to take the data, they are able to instruct the community, the mothers, the caregivers about what needs to be done, what should be avoided. So they are the backbone, and they are there very much in place. So now we will come to the actual how we do the work. So all this data that we need to collect, how is it collected? So usually these workers, they have to make the home visits, or else there are Anganwadi centers in each hamlet. So they have to go to these centers to collect the data of the children, and then they have to manually enter this into registers. And mind you, the registers are different registers for each type of a beneficiary group. So pregnant women will have a different register. The lactating mothers, like who have delivered, they will have a different register. The children, they will have a different register. The initial 45 days after birth, that will be a different registers. So they had to carry many registers, and they had to make those entries into the registers. Then the compilation of the data would be done at the end of the month, because obviously 20 kilometers, they cannot, every now and then they cannot come, right? So they will come at the end of the month, and then they will compile give the data to the supervisor and the manager, and the data will get compiled. So There were many challenges in this, because the challenges were where the data entry had a problem, there were delays, and so all this resulted into a problem that we could not monitor exactly what is happening, what is the impact, what are the problems, what are the weaker links, and accordingly redefine our intervention strategies, which will make the project more effective. So that is when we thought that we need to uh, really do something different, and to share the difficulties, exact difficulties on the field. I think Mr. Naresh Dhanwa will be the best person to do it, because he is the manager health. He actually started as a driver with our organization, and who, with a sheer dedication and a passion to learn, he has completed his BA, and then he did his post graduation diploma course from SP Jain Institute, and he is now looking after the center administration. He is the supervisor, he does the supervision of all the health programs, and he basically compiles the data, and he finalizes the reports. So he is the best person to share what difficulties he faced, what were the challenges in doing this. So I will now hand over to Mr. Naresh Janwa. Please go ahead and share your experience. I will stop sharing. Naresh, you can take up.
या
You
थैंक यू
start.
मैम।
Yeah.
तुम आप स्टॉप कीजिए, मैं यहाँ से मेरा शेयर करता हूँ।
Yes, I'm
या
stopping.
या
And in case
जस्ट गिव मी
anybody has any question in between, you can drop us the comments. We'll take them up at the end.
Yeah.
Yes.
Minimize.
नमस्ते। स्क्रीन दिख रही है मेरी?
हाँ जी, हाँ।
मैं इसको कोशिश करता हूँ प्रोजेक्ट करने की। या मेरा नाम नरेश, और मैं हेल्थ मैनेजर करके यहाँ पे जिम्मेदारी निभाता हूँ अपने भोपोली कॉटेज सेंटर से। तो ये जो जो भी हम लोग प्रोजेक्ट इम्प्लीमेंट करते हैं, तो उसका डेटा रखना, डेटा कलेक्ट करना बहुत ही इम्पोर्टेंट पार्ट है। हम जो 25 विलेजेस में मदर एंड चाइल्ड केयर का प्रोग्राम इम्प्लीमेंट करते हैं, तो उसमें सालाना हर साल 700 मदर्स, प्रेग्नेंट मदर्स वहाँ पे हम रजिस्टर करते हैं। उनमें से 650 मदर्स डिलीवर्ड होते हैं। तो उनका पीएनसी केयर और बच्चों का, छोटे बच्चों का न्यूबॉर्न का पीएनसी केयर, ये हमें साथ में उनको देना पड़ता है। तो पूरे सब ये जो बच्चे हैं 0 से लेकर 5 साल तक के, कुछ करीबन 3,000 बच्चे का मॉनिटरिंग हर महीने हम करते हैं। तो इस ये सब काम करने के लिए हमारे पास जो टीम वर्क है, उसमें 48 हेल्थ वर्कर्स है जो अपने अपने गांव में रह के वहीं पे काम करते हैं। और इस 25 विलेजेस में हम लोगों ने 5 एमपीडब्ल्यू एम्प्लॉय किए हैं, जिनको 5-5 गांव की जिम्मेदारी दी है। और हर एक एमपीडब्ल्यू के साथ में एक 10 एमपीडब्ल्यू सीएचवी साथ में काम कर रहे हैं। तो ये दोनों मिल के ऐसे एक हर एक काम को पार्टिसिपेट करके करते हैं। सॉरी। तो इसमें जो डेटा कलेक्शन होता है वो कौन से एरिया में होता है, तो उसमें एक बार महिला, प्रेग्नेंट महिला का रजिस्ट्रेशन हुआ, तो रजिस्ट्रेशन से लेके उसकी डिलीवरी तक पूरा एएनसी केयर का डेटा हमको मेंटेन रखना पड़ता है। उसके बाद उसका डिलीवरी आ जाता है, तो डिलीवरी होने के बाद डिलीवरी डिटेल्स का डेटा हम लोग कलेक्ट करते हैं। उसके साथ साथ मदर का जो 1.5 महीने का पीएनसी होता है डिलीवरी से लेकर, तो बच्चे का पीएनसी और मदर का पीएनसी पूरा उनको केयर देके उसका जो डेटा है वो हमको नोट डाउन करना पड़ता है। और जो बच्चे, मैंने जैसे पहले बोला कि 0 से लेकर 5 साल तक जो बच्चे हैं, तो उनका हर महीने वेट लेना, उनका हाइट लेना, फिर वो सब रिकॉर्ड करना, उसके जो मस्टर्स दिए गए हैं, रजिस्टर दिए गए, तो उसमें वो हम लोग रिकॉर्ड करते हैं। तो ये सब करते समय बहुत सारे डिफिकल्टीज भी आते हैं। जैसे कि कभी कभी हेल्थ वर्कर गांव में विजिट कर रहे हैं, तो कुछ टाइम पे मतलब उन्होंने डेटा लेने की कोशिश की, तो कहीं कहीं पे फिर कुछ प्रॉब्लम्स होते हैं जिसमें इनकरेक्ट भी डेटा कवर हो जाता है या रिकॉर्ड हो जाता है। फिर ये सब जो डेटा है ये उनके लिए जो रजिस्टर दिए गए हैं उसके ऊपर ही नोट डाउन करते हैं, और बाद में हम वही डेटा यहाँ पे एक्सेल में एंट्री करते हैं। तो ये थोड़ा सा जो काम है ये लेंदी प्रोसेस है। उसमें बहुत सारी जगह पे कुछ रिकॉर्डिंग में गलती हो जाए तो फिर रॉन्ग डेटा हमारी रिपोर्ट में आ जाता है। इसका एक दो फोटो बता रहे हैं कि जब ये हमारी हेल्थ वर्कर होम विजिट करती है, बच्चे का वेट लेती है, और वेट लेने के बाद वो उसका जो ग्राफ बुक है उसमें वो प्लॉट करते हैं कि ये बच्चा कौन से ग्रेड में अभी बैठ रहा है। उसके हिसाब से वो पेरेंट्स को बताते हैं कि आपका जो लड़का है ये जोन में आ रहा है, मतलब ये एबनॉर्मल है या नॉर्मल है, ये उसको बताना आसान रहता है। उसी तरह से फिर अगर पीएनसी या एएनसी विजिट रहेगी तो उसको भी जांच करके उसके लिए फिर अलग फॉर्मेट है जो निचले वाले फोटो में दिखाया है, वो उधर सब मैन्युअली वहां पे नोट कर रही है। हर एक फॉर्मेट पे मैन्युअली कलेक्ट होता था, तो उसमें से वो डेटा हर एक विलेज के हिसाब से हम लोग ऐसे नोट करते थे हर महीने बैठ के। जिसमें अभी एक विलेज का सीट है जिसके जितनी सारी प्रेग्नेंट वुमेन्स है उनका पूरा डेटा ये लंबे सीट में एंटर करना होता था, जिसमें पूरे 59 कॉलम्स में ये सब डेटा बटा हुआ है। तो ये मदर का एएनसी डेटा और डिलीवरी डिटेल्स। ऐसे ही अगर हम दूसरा डेटा देखते हैं तो उसमें वो चाइल्ड मॉनिटरिंग का डेटा है, उसका भी शीट काफी लंबा है। ये भी विलेज के हिसाब से रखा गया है अभी। इसमें हर एक विलेज में जितने भी बच्चे जन्म लेते हैं तो उनका रिकॉर्ड विलेज के हिसाब से इसमें नोट डाउन होता है, और हर एक बच्चे का 5 साल तक का लंबा डेटा इस एक्सेल में शीट में चलता है। अगर आप इसमें देखेंगे लेते हैं तो ये बच्चे का जन्म से लेके अभी ये जो बच्चा है ए लाइन का, ये दिसंबर 19 में उसका बर्थ हुआ है, तो तब से लेके वो 25 तक उसका डेटा ऐसा लंबा चलता है। और इसमें हम लोगों ने कोशिश की है कि हमको जो रिपोर्ट के लिए जो बच्चों का ग्रेड चाहिए कि इसमें सब बच्चे नॉर्मल में कितने हैं, फिर येलो में कितने हैं, रेड में कितने हैं, ये फिल्टर आउट करने के लिए हम लोगों ने यहाँ पे कुछ कलर्स कोड यूज किए हैं जिसके जरिए हम उसको समझ सकते हैं कि भाई ये बच्चे अभी ग्रीन में आए तो ये नॉर्मल जोन में है, कोई बच्चे अगर रेड में है तो रेड में जोन में गए हैं। तो इस तरह का पूरा रिकॉर्डिंग करके फिर इस इधर से फिल्टर आउट करके बच्चों का मंथली एक स्टैटिस्टिक निकलता है, जिसके अंदर हम बच्चों को ग्रेड वाइज उनके नंबर्स रिपोर्ट के लिए मेंटेन करते हैं। तो इस तरह का काम हम लोगों ने ये साल में कुछ जून तक इस तरह से मेंटेन किया है। यस, वो वीडियो काफी इंटरेस्टिंग था लेकिन प्ले नहीं हुआ, सॉरी, क्योंकि उसमें मैंने एक शीट का वीडियो डाला था जो ऐसा 1.5 मीटर का लंबा है।
नो प्रॉब्लम, नो प्रॉब्लम, कोई नहीं।
हाँ उसमें वो जो फॉर्मेट हम लोगों ने एसएनजीओ प्रोजेक्ट हम लोग आरसीएच के लिए चला रहे थे, रिप्रोडक्टिव चाइल्ड हेल्थ के, तो उसमें रिपोर्टिंग के लिए उस तरह का डेटा हमें मेंटेन करना पड़ता था, तो वो बहुत ही हेडेक वाला काम था, लेकिन वो हम दिखा नहीं पाए। अभी ये सब डेटा कलेक्ट करते समय जो भी चैलेंजेस हम लोगों ने फेस किए उसमें एक तो डेटा कंपाइल करने के लिए हर महीने महीने के एंड में दो दो दिन हम लोग यहाँ पे सब इकट्ठा होते थे, उसमें हम दो सुपरवाइजर एंगेज होते थे पूरा दिन, और दोनों दिन मिलके फिर सब डेटा यहाँ पे कंप्यूटर में शिफ्ट करते थे। तो इस प्रोसेस में अगर कोई सीएचवी उस दिन यहाँ पे प्रेजेंट नहीं रह पा रही है तो उसको फिर अलग से विजिट करके या उसको टेलीफोन कॉल करके उसका जो डेटा है वो हम लोग लेते थे, तभी हमारा पूरा शीट कंप्लीट होता था। उसमें ऐसा भी होता था कि अभी डेटा तो मिल रहा है लेकिन कुछ सीएचवी ने कुछ डेटा जो है वो ठीक से भरा नहीं है, कहीं पे अधूरी है, तो वो फिर वैसे ही छूट जाता था, तो आधा अधूरा डेटा हमें मिलता था। और एक ये रिपोर्ट लेते समय हमारे ध्यान में एक बात हमेशा एक आती थी कि हम लोग जिनका डेटा ले रहे हैं वो एंड ऑफ द पॉइंट ले रहे हैं, मतलब एक एएनसी मदर जो रजिस्ट्रेशन से लेके जाती है डिलीवरी तक, तो उसको बीच में क्या क्या तकलीफ होती है, कहीं कहीं कौन कौन से फैक्टर उसके हाई रिस्क वाले थे, तो इसके बारे में हेल्थ वर्कर के मुंह से हमको रिपोर्ट के बारे में मालूमात होती थी या इंफॉर्मेशन मिलती थी। तभी हम लोग सोचते थे कि वो जिस टाइम में उसको ये सपोर्ट होना चाहिए था या काउंसिलेशन वो मदर को देना चाहिए था, उसका टाइम निकल गया है। तो कहीं ना कहीं हमारा जो तरीका है वो कहीं ना कहीं बहुत डिलेड है, तो इसको हमें सुधारना चाहिए या इसके ऊपर काम करना चाहिए। ये हमें बहुत बार समझ में आता था ये सब मंथली डेटा कलेक्ट करते समय। और कभी कभी डेटा रिकॉर्डिंग में भी गलतियां होती थी। जैसे कि अगर सीएचबी ने बोला है कि अगर एक बच्चे का वेट सर ये 2.2 kg एज बर्थ वेट है, ये आप नोट कर लो, तो ह्यूमन एरर है, यानी मेरे ही हाथ से अगर वो 22 किलो 22.0 करके एंटर किया गया तो वो प्रॉब्लम होता था। जब तो ये पता कभी चलता था जब हम लोग जब भी महीने का बर्थ वेट का ये निकालते हैं एवरेज, बर्थ वेट का, तो उस टाइम पे पता चलता था कि कहीं ना कहीं पे तो डेटा में कहीं पे रॉन्ग एंट्री डाली है, क्योंकि अभी बर्थ वेट जो है 2.7 2.8 या 2.6 आना चाहिए, वो कहीं पे 4 किलो 5 किलो ऐसा बता रहे हैं, यानी कहीं ना कहीं पे तो एंट्री में गड़बड़ होगी। तभी रीचेक करके वो पता चलता था कि यहाँ पे कुछ ना कुछ गड़बड़ हुई है। तो इस तरह से फिर हर एक विलेज में जितनी भी महिलाएं डिलीवर्ड हुई है, वो डिलीवर महिला का एक्सेल शीट से अलग अलग मतलब फिल्टर करके उस महीने के लिए वो सब सेल्स या रोज कॉपी करके एक अलग से शीट बनता था। इस तरह से 25 विलेज का एक अलग से इस महीने के लिए डिलीवर्ड का रिपोर्ट बनता था। तो काफी सारा समय और काफी सारा वक्त इसमें हमें देना पड़ता था। और बाद में जब भी हम लोग ईयरली रिपोर्ट करते हैं या हाफ ईयरली रिपोर्ट करते हैं, तभी भी अगर कुछ ना कुछ इन्फॉर्मेशन इसमें आई नहीं है किसी कॉलम के अंदर, तो फिर पछतावा होता था कि ये इन्फॉर्मेशन हम लोगों ने लिया है नहीं, या फिर ये इस इन्फॉर्मेशन में हम लोगों ने ज्यादा फोकस नहीं किया कि ये सीएचवी के पास से आना चाहिए। तो इतनी सारी चैलेंजेस, इतनी सारी डिफिकल्टीज हम लोगों ने इस तरह के काम में करते हुए फेस की है। तो आगे जाके हम लोग हमेशा बोलते थे कि हमें अभी ये जो मतलब ये स्मार्ट एज चल रहा है कि स्मार्टफोन सब इस्तेमाल कर रहे हैं, तो अपना जो काम है, जो काम करते हैं, वो साथ साथ में किस तरह से रिकॉर्ड हो जाएगा, इसके ऊपर कुछ हमें सोचना चाहिए। जैसे कि सीएचबी ने काम किया है किसी महीने की पहले है हफ्ते में वो 7 तारीख को लिस्ट, लेकिन उसका टोटल रिकॉर्डिंग हम करते हैं महीने के 30 तारीख को। तो इसमें बहुत सारा फासला हो जाता है। इसलिए जो काम प्रैक्टिकल होता है वो साथ साथ में रिकॉर्ड कैसे होवे, इसलिए कुछ ना कुछ टेक्नोलॉजी का इस्तेमाल करना चाहिए। तो फिर हम लोगों ने गूगल फॉर्म इस्तेमाल करने की कोशिश की, लेकिन वापिस अपना जो पूरा ट्राइबल एरिया है यहाँ पे नेटवर्क का इश्यू होने के कारण गूगल फॉर्म भी ज्यादा हम लोग सक्सेस नहीं कर पाए। फिर हमारे जो डोनर्स थे, हम हमें ये कुछ प्रोजेक्ट्स को सपोर्ट करने वाले, उन्होंने ही उनका राय दिया। जब जब भी वो यहाँ पे इंस्पेक्शन या मॉनिटरिंग विजिट के लिए आते थे, तो वो बोलते थे कि आप बहुत अच्छा काम कर रहे हैं, बहुत डेटा आपको आप यहाँ पे कलेक्ट कर रहे हैं, लेकिन इस डेटा को स्मार्टली कैसे कलेक्ट किया जाएगा उसके ऊपर आप जरा सोचो और उस प्रोसेस को इम्प्लीमेंट करो। इसलिए फिर बजट का प्रोविजन, उसमें उसके लिए बजट कहाँ से लाया जाएगा, तो फिर सुनील सर की मदद से और ये जो प्रपोजल रखा गया कि इस तरह से हमको एक एंड्रॉयड बेस्ड एक ऐप डेवलप करना है, तो इसके लिए बजट की सुविधा कहाँ से होगी। तो सुनील सर ने ये एलएनटी के सामने प्रोजेक्ट प्रपोजल रखा, और एलएनटी ने हमको इसके लिए सपोर्ट किया। और फिर ये डेवलप कौन करके देगा, तो फिर उसको उसको ढूंढने का काम चालू हो गया, जिसमें समन और अवनी, ये प्लेटफॉर्म का पता चला, और उनके साथ ये टाइप करके आज जो भी काम अभी खड़ा हो गया है, मतलब अवनी को हम पिछले 5 महीने से 5 6 महीने से उसमें काम कर रहे हैं। तो अभी हमको अच्छा लग रहा है कि हमें जो चाहिए था उस तरह का काम अभी हम रिकॉर्ड कर रहे हैं, तो ये एक हमारे लिए बहुत खुशी और आनंद की बात है। मुझे अभी आगे का जो इन्फॉर्मेशन है, मैं मैडम को रिक्वेस्ट करता हूँ कि ये जो काम हम लोगों ने शुरू किया है, जिसमें ऐप डेवलपमेंट का काम किस तरह से हुआ, तो वो अपने हाथ में लेके मैडम आगे प्रोसीड करें।
नरेश जी, मेरा एक क्वेश्चन है।
हाँ।
हाँ।
क्योंकि अभी आप फील्ड में काम कर रहे हो, आपकी टीम आप देख रहे हो कैसे यूज कर रहे हैं, तो वो जो उनका
हम्म।
ट्रांजिशन था, पहले वो पेन एंड पेपर पे लेते थे या फिर गूगल आप लोगों ने शीट भी यूज,
हाँ हाँ।
वहां से एक एप्लीकेशन अवनी में आने का, आपके टीम के साइड से वो जर्नी कैसा था? उनको डिफिकल्ट लगा, इजी लगा? अभी 5 महीने वो लोग यूज कर रहे हैं ऑलमोस्ट, तो वो उसके
यस, यस, यस।
थोड़ा बताएंगे क्या?
हाँ, हाँ। वो भी उनको शुरुआत के 1-2 महीने के लिए थोड़ा डिफिकल्ट था, क्योंकि हर एक इसमें जाने के लिए उनको खुद को डिफिकल्ट लगती थी। तो
हम्म।
अभी मतलब रेगुलर यूज करने के बाद अभी आसान लग रहा है। तो हमारे सभी हेल्थ वर्कर, एक नॉर्मली एक ही हेल्थ वर्क है जिसका एजुकेशन कम है, उसको डिफिकल्टी लग रही है, उसको कोचिंग करना पड़ता है। बाकी अदरवाइज बाकी सभी हेल्थ वर्कर अभी जैसे कि काम करते हैं, तो उसके साथ साथ स्टेप बाय स्टेप वो उसके अंदर डेटा रिकॉर्ड करते हैं। जैसे कि मदर, प्रेग्नेंट मदर, ये पता चला है कि इस मदर ये प्रेग्नेंट है, इसका भी रजिस्ट्रेशन करने का है। तो रजिस्ट्रेशन का जो प्रोसेस है वो कैसे 3 स्टेप में पूरा होता है, वो उसको अभी मालूम हो गया है। तो उसके हिसाब से अभी डेटा ये जो अवनी में दिख रहा है, मैं रिपोर्ट में, तो मुझे लगता है कि अभी ये जो प्रोसेस है ना, वो सीएचबी के लिए भी आसान हो गया है, और उन्होंने अडेप्ट किया है ये।
ओके
मैडम, मैं
नरेश।
आपके सवाल का जवाब दे सका?
हाँ हाँ, तो आई थिंक जितना मुझे समझ आया, मोर एंड मोर वो ट्रेनिंग और यूज करके करके
यस,
दे आर बिकमिंग
यस, यस।
कंफर्टेबल, और अभी वो अच्छे से कर पा रहे हैं फिर।
हम्म, हम्म।
So Naresh, you can now
स्टॉप
stop sharing.
शेयरिंग।
मैं मेरा शेयर
यस।
करना चालू करती हूँ. And just in connection with the whatever he said, I would like to say कि ये काफी लोग ना यहाँ इसमें से इवन फोन स्मार्टफोन फ्रेंडली नहीं थे. तो काफी सारा ट्रेनिंग और हैंड होल्डिंग करना पड़ा, और वो किया तो जाके आज तक ऐसा हम बोल सकते हैं कि वी हैव बीन एबल टू मेक देम यूज द ऐप, and we hope that with a gradually it will improve. So we are hoping that. So anyway, so I will now share my journey with Samanvay Foundation and the Avni platform. um, uh,
Presentation.
Presentation mode. 1 minute. Yeah. So when we started with the Samanvay, it actually it means the literal meaning of that is coordination and mutual connection. And it's so true that with Team Avni, they had to coordinate with us who were homeopaths, that is doctors, having absolutely zero technical background. So we used to think that we know this, so this has to be whether this has to be communicated to the computer, इतना simple सी चीज है वो ध्यान में ही नहीं आता था कि we have to tell that temperature, for example, if there is a fever, then you have to check the temperature, and if the temperature range is between not between a certain range, then it will have to be labeled as fever. So computer will have to be taught to recognize this logic, and all this we had to the team taught us how to think to develop the app. So all the logic, everything had to be actually trained by them to us, and I think they must have really faced difficulties when they were dealing with us, but they were very quite understanding, very friendly, not getting irritated even if we make same mistakes 2 3 times. So with all this, now then we could develop this app, and which can overcome our challenges. So I'm very happy that we have come up to this. So I will just share in brief how we took steps to achieve what we achieved. So we had shared initially all our data keeping formats and the reporting formats. And immediately, technical team, recognized the discrepancies between the data kept and the report formats. The headings were not matching. Some of the data points were missing. So we had to then again redefine and redevelop these formats to suit the logic. So logic was the most important thing, I think, that I learned even personally, that you have to connect each and every data point inside one form, and you have to connect it to the other forms also. Like suppose like you have a form of ANC, that is after pregnancy registration, you are taking up the information of the pregnant woman. Now that has to also get connected to the information that you will collect during delivery and even after delivery. So there has to be some linkage, and that was something that we learned. Then for this, we had made those scoping sheets. They had provided us with the formats, and where we had to, write, enter every minute detail. That is what you need to ask to get this data. When do you want to ask? So some of the datas are time bound. Like suppose if you are, examining a woman in pregnancy in say 7th month, and someone who is just in the 3rd month, the data that you will need for a woman in 3rd month and a woman in 7th month will be different. So you have to tell when you want to ask this data, when you should not ask the data. So listing out all the probable answers, so that for especially when we are using it with the workers who are not like 7th 8th standard pass, they will be it will be easier for them to just tick the answers. So you have to actually list out all the probable answers. You have to list out all the normal abnormal ranges of each and every data. And that is how the scoping sheets were so enormous and big. And when sometimes now when I look at them, I really think whether I really did this much of scope sheets works. I remember I used to say jokingly that I am in a school, and every day I get a homework, and I have to complete it. And if I don't complete it, and the next day the Avni team is going to say, "Madam, kya आपने ये नहीं किया complete? अभी कभी करेंगे." So I used to spend a lot of time, and I think it was a very enriching and a learning experience. And you have to have all this in place, and even the treatment advice, everything, whatever you want the workers to know has to be fed in the system. But ultimately when you see the cars on the dashboard, you are pleased that yes, okay, we are able to see what we needed to see. And absolutely no vagaries, so no chance of any errors, no chance of any vague answers, nothing. So it was really very clean data. Data was absolutely rubbish when we used to keep it in our uh, uh, registers, manual entries. So this was a very clean data which we could use afterwards. So dashboard started showing us different cards highlighting different categories. That was like a miracle for us. Like, oh, okay, in one click you are able to see so much statistical data. And even all the present, all the digital, with all the digital things, with one click you are able to see everything. We were able to visualize the growth chart. Just a few some time back, Naresh had shown one register having that growth chart. Now that growth chart you had to actually manually put those points, and then only you could see. Here you could just click on the growth chart and the child's growth chart will be seen. It was just like a magic. So wonderful experience. Then came the next step of the dry run on the UAT platform, where we had to create the data of our all our previous work, so that whenever this particular beneficiary will come, we will be able to enter the current data. Unless the particular individual is there in the system, you will not be able to enter. So we had to create lot of upload sheets. And that is when we realized that the data had so much of a problem that we had to take external help from individuals who were very generous enough to come and help us out in cleaning the data. So accuracy was most important. Whenever I used to upload any sheet and it used to show that you have errors, I used to sit and think, oh my god, now what are the errors if I cannot upload. I had come to one point when I had told the team member that I don't think that I'll be able to upload the data, because every time I'm trying and every time it is showing something, some error or the other. But yes, again, Avni people always were there to support me and help me, because here each beneficiary was recognized by a unique number. And even if a very small change in the number occurs because of some oversight, then that data was getting rejected. So uploading the previous data was a big task, and then the new data entry. So both the things were going on simultaneously on this UAT platform. Simultaneously we had to undertake the training. So the core team of managers, supervisors, and MPWs, we were training, and the training continued, like hands-on training, and then any difficulty, then again sort it out. So this is what it took a long time, but we had to monitor all the errors, and we had to identify and we had to report, so that the app, whenever it comes into its final product, it will not have any errors. So it was again, the errors also we had to report on a very well designed format. So nothing oral, nothing on WhatsApp groups, nothing on chats, everything on that particular format, and which was on the drives. So it was a very systematic work where even the elimination of errors was very easy, and the app became kind of foolproof. So this is my learning, this is my personal learning, and I think that all those who want to work in such a field, I think they should know that actually computer knows nothing. It knows only what you feed. So if at all the computer starts showing some errors, you have to take the feedback that no, it is some difficulty that I have created, and it's not a fault of the computer, because everything is based on logic and there is no intuition. At times, as human beings, we do have the intuition which will not be there in the computer, and every form or piece of information has to be logically correlated. Then once you are able to streamline all the forms with the logical reasoning, then you are able to see the correct and the proper form in the app. One example I will give you of a high risk pregnancy. Earlier I talked about the fever. Now we, in our formats, in the manual formats, we never had a very specific field for recording the temperature, because when once the woman comes and she says I have fever, we will examine, we'll note down, and that's the end of it. If there is a fever, there is a fever. But when you go to the computer, and when I had listed out in high risk pregnancy fever as one of the factors for detecting high risk, the team member asked me, Madam, where is the temperature? We have not taken temperature. So then how will the computer understand that this is a high risk pregnancy? So we had to go back to even data forms, and we had to make those additions. So now when I look at the data forms or the data that is getting collected, I think that we are actually collecting very accurate data, and we are covering everything. So I think that this is a very this also results in a very good clinical practice. As a clinician also, I know that if I need something, then I have to look for it. And this also helps in general for any other work, because then you start thinking in that logical format. So I think this whole experience was a very enriching and educative one. So as I said earlier, that it was a magic to look at the graphs and all that, but then that magic has to be created, and you have to put a lot of effort to do that. So now I think I have covered the aspect of how the app got created. Now I would request my field workers to share how they have been using it and what is their experience. So I would request now this Harsha Shelar is a very dynamic person. She has been working as a multi-purpose worker in the health sector. She's there now for the past 10 years almost. And she has 5 villages under her. She has to monitor the work of 10 community health workers, and so covers around a population of 7 to 8,000. And she has to move in a radius of 2 to 3 kilometers. Apart from that, she has to come to the center also. So I now request Harsha Jyoti to talk about her experience. I will share from here only. I think Harsha will be able to talk.
नमस्ते, मी मराठीतच बोलते.
Yes. No problem.
बोल,
Go
बोल.
ahead. Go ahead.
वहिनी.
माझ्याकडे 5 गावांची जबाबदारी आहे आणि त्याच्यामध्ये एकूण 10 CHV आहेत. त्यांच्या कामाची पूर्ण पाहणी करण्याची जबाबदारी माझ्याकडे दिलेली आहे. अवनीच्या अगोदर आम्ही जेव्हा पाड्यामध्ये जायचो, तेव्हा आम्ही घरातून निघताना पूर्ण ब्लँक जायचो. तिथे गेल्यानंतर आम्ही त्या CHVचा रेकॉर्ड बघायचो. तेव्हा समजायचं की आज आम्हाला ह्या लाभार्थ्याला भेट द्यायची, किंवा ह्या लाभार्थ्याकडे असं हाय रिस्क आहे तर हिच्याकडे जाऊन यायचं आहे असं. पण आता आमच्याकडे अवनी ऍप्स आल्यापासून आम्ही घरी बसूनच आम्ही नियोजन करू शकतो की आज आपल्याकडे इतक्या हाय रिस्क पेशंट आहेत किंवा इतक्या लाभार्थ्यांच्या भेटी आहेत, तर ते आम्ही घरातूनच निघताना नियोजन करतो. किंवा नंतर मग जाण्याच्या अगोदर अजून 4 ठिकाणच्या आमच्या असतील CHV, त्या ठिकाणी आम्हाला जायला जमत नाही, अशा वेळेस त्यांना कॉल करून आम्ही सांगतो आणि एका ठिकाणी जाण्याचा प्रयत्न करतो. असं आमचं आता कामाचं नियोजन घरीच बसून असतं. पहिला आम्ही पाड्यावर गेल्यानंतर करायचो. त्याच्यानंतर जोखमीच्या माता आहेत, त्या आम्हाला पाड्यावर गेल्यानंतर समजायच्या, पण आता त्या आमच्या अवनीच्या ऍप्सवर लगेच आम्हाला दिसून येतात. मग त्यांच्यासाठी काय सल्ला असावा, कुठे दवाखान्यात जायचं, किंवा आपल्या डॉक्टरांकडून त्यांना काय सल्ला देता येईल, ह्याच्यासाठी आम्ही आता लगेचच प्रयत्न करतोय. त्याच्यानंतर डाटा कलेक्शन होतं. ते जेव्हा आम्ही पाड्यावर जायचो, जर 1 तारखेला डिलिव्हरी झाली तर ती डायरेक्ट शेवटच्या दिवशी आम्हाला समजायची 30 तारखेला. किंवा मग सेंटरवरती ती मध्ये काही त्या बाळाला त्रास झाला किंवा आईला त्रास झाला ते समजायचं नाही. पण आता अवनी मुले ते 1 दिवसाची भेट, 3 दिवसाची भेट, 7 दिवसाची भेट ही लगेच दिसून येते आणि सर्वांना लगेच समजते एका वेळी. थँक्यू.
I hope people have understood, but if they have not, then I will just sum up. So with the app, what is happening is that the data is getting entered real time, and they are able to see it real time. So whenever they are out for the work, they are able to plan, and then with a planned thing, whenever you do any work, I think the efficiency is definitely ensured. And so that is what is the whole experience. So she is able to do her work, she is able to manage her CHW's work, she is able to monitor them. So I think that's the advantage of the app. Now I think I have to request my community health workers. They are there in the villages, their own hamlets. I hope that they get the network, and I would request either Surekha or Rekha, whoever, just tell me who is going to talk, and please talk.
रेखा, तुम्हाला बोलायला सुरुवात करता येईल ना प्राप्ती?
म्यूट ऑफ करायला.
हा, म्यूट असाल तर हे करा.
अनम्यूट म्हणजे म्यूट. ठीक.
So I will in the meantime I will share that these are my 2 of my workers out of the 48. One of the worker is has been doing a visit to a pregnant woman, and she is entering the data in that register. And this other woman, Rekha Babar, is actually near the mobile van. She is handling the patients or the beneficiaries who have come to the mobile van to get the service done. Yes, so I hope रेखा तुला आता बोलता येणार आहे का, किंवा सुरेखा कोण बोलणार आहात?
रेखा दिसते. रेखा सुरुवात कर.
हा.
नमस्कार, माझं नाव रेखा.
हा. बोल रेखा.
बोला ऐकू येतंय.
मुले मला खूप फायदा झाला. पहिले आम्हाला दप्तर घेऊन जायला लागायचं, रजिस्टर, गरोदर बायांचं, स्तनदांचं, तसंच बालांचं, असं रजिस्टर खूप असायचे. आणि आता आम्हाला अवनी आल्यामुळे ते खूप सोपं झालं. सोपं म्हणजे मदत झाली, आणि त्याच्यामुळे आम्हाला आता ते लगेच समजायला लागलं की ही माता जोखमीची आहे की साधारण आहे. ते लगेच अवनी मुले आम्हाला दिसून येतं. आणि ते तसंच भाऊंना समजतं, मॅडमना समजतं, ताईंना समजतं. मग लगेच आम्ही त्यांना सल्ला देतो. भाऊ सांगतात की ही जोखमीची आहे, तर मग त्यांना सल्ला द्या, असं वगैरे सांगतात.
ओके रेखा, मग आता सुरेखा झाली का जॉईन?
हो.
हा, मग बोल सुरेखा, आता तू बोल, तुझा काय अनुभव?
नमस्कार, माझं नाव सुरेखा संतोष शेलका. माझ्याकडे 2 पाड्याची जबाबदारी आहे. मी CHV म्हणून काम करते, आणि आता जेव्हापासून आम्हाला अवनी ॲप दिल्याबद्दल आम्हाला हे काम सोपं जातं. वेळोवेळी आम्ही माहिती भरतो ती PNC गरोदर, PNC आणि NC माता. आता हे सर्व काम सोपं जातं. पहिले रजिस्टर घेऊन फिरायचो, आता रजिस्टर नाही, आता मोबाईलवरच सर्व माहिती भरतो आणि विचारून तिथेच भरतो त्यांची सर्व माहिती. ते आम्हाला आता सोपं पडतं. थँक्यू.
सेंटर पर्यंत यायला लागत नाही ना रिपोर्टिंग साठी?
हो, तिथे यायला लागत नाही. आता आम्ही घरीच सर्व रिपोर्ट तयार करतो मोबाईलवरच. मुलांची वजन वगैरे सर्व.
मॅडम, पहिला आम्हाला म्हणजे कसं रजिस्टर करतो आम्ही इथे महिन्याच्या स्टार्टिंगला, आणि मग तिथे जाऊन 30 तारखेला करावा लागतो, आणि इथे 15 तारखेला, 12 तारखेला असं आमचा रजिस्टर होतं पहिलं. आता तसं नाही, आता लगेच होतं. त्याच्यामुळे खूप फायदा झाला.
बरोबर. छान. So, in short, what used to happen is they used to carry so many registers. So they used to carry one
Huge
huge bag, having all the register, and then sometimes they had to carry the weighing machine also or BP instrument also. So ultimately, they had to really lug out a lot of luggage and travel in those different difficult terrains on feet. Now with the app, what has happened is that they just carry that single phone and do the recording, and then it becomes very easy, and they don't have to come back to the center for reporting again with the whole lot of registers. So what used to happen is, to in order to avoid that, they used to make the entries in the diaries or some small papers, and then that is how the errors used to compound. So I think with the app now, that problem has been taken care of. Thank you, Surekha. Thank you, Rekha. छान म्हटलं तुमचं बोलणं ऐकून.
हो.
Yes. So ultimately, what happens is that Avni makes it easy and accurate. So all the visits, once you register, you know what all visits are planned. So you have to, all the alerts come on the dashboard. You know what are due visits, what are overdue visits. The managers, the supervisors, they know exact numbers. They know the high risk cases. They can plan the extra visits accordingly. They can instruct the workers. Monitoring has become easy. You don't have to visit the village. You can just look at the app and say whether work is occurring properly or not. And monthly reports was a major problem which Naresh had shared. Now it is just a click away. It is just like, as I said again, it's like a miracle. And report download again. No need to put any filters or anything. It is all available to you. Just you go to the dashboard and on the support, and you say what report you want, and it is available. So I think Ravni really has made it life very easy. So now, with the help of Avni, what further? Like, okay, we are getting the help of recording and data compiling. How it will help? So it will help in identifying the problem areas, and we will be able to find the weak links and define the different strategies so that the problem can be managed better. Even so, we have work on other verticals like education, self-help groups. So that work also can be somewhere entered on a similar way. We can digitalize. Now that will be really a great thing to happen, which can also have the linkages with the vertical of health. So we can actually plan and see whether education makes any difference to a person's health or not, whether a livelihood options getting better, whether that has a positive effect on the health or not. So this I think the self-servicing platform that is provided by Avni will be really helpful. I would really love to explore that. And so in this particular way, the holistic healthcare can be mapped and it can be implemented anywhere else. So that is, I think, something that really will be great. I think I hope I have covered everything. Is there anything else that you want me to say, or is there any question? I can always.
Sujante, can you share something about if any new NGO or anyone is looking out for digitalization, or no, if it's looking out to you,
Yeah. Yes.
what would be your thought, or what would you like to say?
Yeah, I had thought about it. So I think that any NGO who is working on some such similar problem, they have to first of all know what is the problem, what is the problem that they are facing. For solving that problem, what is the probable data, all the data points that they will need, what all reports they will need, and each data, why, how they want to have, uh, how each data is linked to the report. If you are able to create this basic structure in your somewhere, and if you approach a platform like Avni, then I think that you will be getting a solution, and it will really be of use, because you will get a app will allow you to understand the problem also better and then plan the strategy. So any NGO who is having similar work can definitely be benefited by digitalizing their services. So I think that is, if there's anything that I can help you out with, any other specific question, I will do that.
Thank you so much, Radhi. Anyone have any other question?
So yeah, Sujata Chi Pooja here.
Yeah.
I just wanted to ask, is there is any growth in your day-to-day work after using Avni? Like you used to do a 10 or 5 or 10 uh, visits at the time, and now it has grown to 15, 20 or per day or anything like this kind of increment. Have you seen in your app while using this?
Yeah, so thank you, Pooja. This is a very important question. In fact, last time when we had a meeting, we had this discussion. I think the workers still need to, work on the app so that they are able to work efficiently. So cover lot more number of beneficiaries. I would say that I had instructed them that rather than increasing the number of beneficiaries, if you plan and go, then you can work more on educating and orienting them, because then you can plan the work and coordinate with education orientation aspect, because that's one of the challenges that we face even today. What happens is behavior change is a big problem, and that if you want to achieve that, then you will need to go on talking to them very regularly, and with planned visits, I think you will be able to talk to them more regularly, and I think that will make a lot of difference. So yeah, rather than numbers, I would say that the quality will improve a lot.
Yes, the work streamline has run properly with that.
Yes.
Understood. Thank you.
Yeah. So if there's nothing further, I can say thanks a lot for L&T, who provided the very much needed budgetary support, and Team Avni for making this a very educative and enriching experience. I am sure that they also must have got some learning about how the community work goes, what are the challenges, and I think they also. So it was, I think, mostly a mutually enriching experience. Uh, and So I would really like to thank on behalf of MLD Memorial Trust, Team Bhopoli, for giving us this opportunity. And thank you very much.
Thank you so much, Sujata ji, Chandrasekhar ji, Naresh ji, and the entire team of MLD Trust. I missed to mention that Sujata ji has been associated with MLD Trust and has been working as a Chief Project Officer since 1986 now.
Yeah, 1986. I was not the. I was a student actually. I was
So
just a student
28, I think 2008 you.
2008. I actually started working at Bhopal. Yeah. So now I'm there, and I have seen a lot of growth, as what Pooja was asking. I have seen a lot of growth, and we do wish to increase our area of services. Hopefully, with this app, that also will be a reality.
Arjun, anything you want to add before we move to the Avni launchpad? Anything from your side?
No, no, nothing major really. Thankful to Sujata ji, Chandrasekhar ji, and rest of the MLD Trust team to share their experience. I think it has been very, very interesting and amazing. We started this journey beginning of this year, and I think this has been really amazing working with you all. I was there in Mumbai to be able to participate in their like the foundation day, and there Avni was also in a way launched, and it was like amazing. The energy, I think, it was filled with energy, laughter. Um, um, uh, though there were a lot of homeopathy based presentations that I couldn't make a lot of sense of. I mean, I was able to understand only at a very, very brief level. But I think being there in that group itself felt like really amazing, and I was able to meet various people otherwise that we just talk on calls and all of that as such. So thankful for that as well. I think, yeah.
Thank you.
Thank you, Sujata ji. Thank you, Arjun. I know we have crossed the time, but quickly I would like to just take your 2 minutes to talk about Avni Launchpad. Most of you must be knowing by now, must have seen our social media ads and have received communication from ours. But those who have joined us newly today, so we are running a special program called Avni Launchpad, wherein if there are any organization who is looking to digitalize their current data collection or data monitoring process, for them we are doing this Launchpad. In which will be, it's like a 9-week journey we'll be doing with them, wherein we'll be providing them free mentoring and consulting. There will be a 2 month of free hosting. We will be doing a 2-day in-person workshop in Bangalore, wherein we will sit with those organizations and try to build their pilot project with them, which they can roll out for a month and see how the application is working. So you must have received those communication social media. Please do spread it out, to all your connects, whom you think will be useful from this. And please spread the word so that more and more people get to know about this event and they can sign up and be a part of the Launchpad. We'll take your 2 minutes. We'll be sending these details on social media and emailing it to you. Would request you to take 2 minutes to share feedback about this session. You can scan this QR code. Let me know if you're able to scan and get the Google Sheet. I will be posting it also. I'm pasting it in the chat bot as well.
Thank you, Anjali. Yeah.
Yeah.
Okay, thanks a lot.
Thank you. You can fill it and send us the feedback, all of you.
Yes.
Join.
Yes.
Thank you so much for your time.